When a witness is about to speak, he or she should introduce themselves and address their comments to the committee. Witnesses need to keep their comments relevant to the bill being heard. Each witness must complete a witness appearance form and leave it on the desk, please. Members of the committee, remember to speak into your microphones so those listening online can hear what the committee is discussing. After the sponsor presents the bill, we will proceed first with those testifying in support, followed by those testifying in opposition, and concluding with those testifying for informational purposes only. For committee purposes, I may have to limit time for those testifying to 3 minutes. I noticed a lot of jackets out in the hallway too. Today we will be hearing 5 bills. After you testify, whether in support or opposition, if you don't mind leaving the room to make room for someone else to come in, that would be very nice for people waiting on the outside. We're going to start with Senator McCreery's bill, SB979 and 1016. Oh, I'm sorry, SB1405. Yeah.
Yep.
Thank you. Proceed, please.
Good morning, Vice Chair Berger and members of the committee. I'm State Senator Tracy McCreery. I represent St. Louis County, Senate District 24. I'm here to present pathologist or audiologist by providing for completion of a clinical fellowship under the direct supervision of a licensed speech-language pathologist in good standing. Right now, current law is very limiting. It says that these folks would have to complete their clinical fellowship under the supervision of a person licensed by the state of Missouri. So this is really this is just language that will open up the opportunities for more speech-language pathologists to be able to practice in the state of Missouri. And anyone you talk to that employs these group of professionals will share that there's a shortage of folks. And of course, we talk about this a lot in emerging issues. We are kind of competing with all of the states around us, and so we want to make sure that Missouri, that we can attract the best and the brightest in this profession. I'm happy to take questions.
Thank you for presentation. Any questions from the committee? Seeing none, first person to testify in support of, please come forward. No one? Testifying? Okay.
Mr. Chairman, members of the committee, my name is Brent Hemphill. I'm here on behalf of the Missouri Speech, Language, and Hearing Association.
Is the mic on? Okay.
Senator McCreery did a phenomenal job of explaining the bill. Due to the issue, we really do have to do this because SLPs are in such huge demand. And so when we joined the compact, I believe 3 years ago, people from other states couldn't comply with the compact because they couldn't get their license. Because they don't do a clinical fellowship by a Missouri licensed SLP. So this is a technical fix, and want to compliment the senator for already getting it out of the Senate.
Any questions of this witness? Thank you for testifying. Anyone else to testify in support of? Anyone to testify in opposition to? Anyone for informational purposes only? Seeing none, that concludes that hearing. We'll move on to Senate Bill 979 and 1016 together. Senator Schroer and Senator Lewis. Whenever y'all are ready, please.
Thank you, Mr. Chair and member of the committee. For the record, it was like this yesterday. I know. We've got senators everywhere in many different committees. For the record, Senator Schroer presenting the annual APR Interform Bill. This year it's Senate Bill 979. I'm going to be brief because I know we have a lot of witnesses for and against this bill, but essentially this legislation is focused on the healthcare crisis in the state of Missouri. And we're going to try to resolve it by improving healthcare access, healthcare outcomes, and by bringing costs down of healthcare in the state of Missouri. Senate Bill 979 modernizes Missouri law relating to advanced practice registered nurses. That's the APRNs you always hear us talking about. And ensures that qualified, experienced providers can practice to the full extent of their training while maintaining appropriate safeguards. Missouri continues to face significant provider shortages across the state, with physicians aging out, a lack of new physicians coming in, and APRNs that are very skilled crossing our state borders to go to other states, which allow them to practice to their fullest extent that they were trained and educated to do. Senate Bill 979 addresses this gap responsibly and deliberately by providing that APRNs who have completed 2,000 cumulative documented hours in a collaborative practice arrangement with a physician and whose license is in good standing still may transition to practice just as they were educated to do, as a vast majority of other states have allowed them to do. You'll hear today many red herrings, as we always do, arguments from people more enthralled with turf wars rather than improving health care in the state of Missouri. One of these arguments is that APRNs are not doctors. They aren't. They're not trying to be. They're also not senators, ballerinas, or trying to be the next leader of Iran. And they certainly don't want to be those either. These are skilled practitioners attempting to join the majority of our states that have witnessed an increase in patient access, an increase in patient outcomes, and an increase in patient satisfaction, all the while decreasing healthcare costs, decreasing unnecessary ER visits, and decreasing the provider shortage. Missouri is missing out on over $30 million plus per year over the next 5 years from the Trump administration because of our archaic rules. And with that, I'll pass it over to my colleague here.
Good morning, Mr. Chair and members of the committee. Thank you for the opportunity to present Senate Bill 1016, which is identical to 979. I think Senator Schroer did a wonderful job of summarizing. I'm just going to add a couple other things. We just passed out a recent study that came from a researcher talking about reflecting on the bill that with less restrictions for nurse practitioners, we see a reduction in readmissions. Anyway, so just a lot of stuff just to look at. And then I think something new to point out is that there are, based on recent information, there are 36 other states that have transitioned to practice or full practice authority. So I know Missouri sometimes doesn't want to lead in some things, and this would put us in the middle. And as the senator pointed out, because of our restrictions with nurse practitioners, we lost on a ton of federal money coming down because of the scoring process and our restrictions with nurse practitioners. And the last thing I want to talk about too is that, where I live, all of our boundary states have either transition or full practice authority, except for Tennessee. And on the doors, when I was working to get here, I heard time and time again that I now practice in Kansas because they have independent or full practice authority. So we are losing practitioners to surrounding states, similar to what the prior senator said with the speech pathologists. So with that, happy to answer any questions.
Any questions from the committee? How many here to testify in support of? In opposition to?
And there's some in the back. There's some in the hallway that couldn't come.
I think for everybody's sake, of time and getting the ability to testify, it's going to limit everyone to 3 minutes. The first person to testify in support of, please come forward.
Good morning, Chairman, committee members. My name is Marcy Marcus. It is. Let me get it closer. Is that better? Okay. My name is Marcy Marcus, and I'm a nurse practitioner that has practiced in Missouri as a family nurse practitioner for the past 25 years. I am nationally board certified. I support full practice authority because I have seen firsthand how current law limits access to care in rural Missouri. At one point, I operated 4 clinics, 3 of them being in rural communities. When COVID-19 hit, my collaborating physician relocated outside of state-required mileage limit. Because Missouri law required the geographic proximity, I was forced to close 3 rural health clinics immediately. Those communities lost access to care, not because of safety concerns, but because of regulatory requirement tied to geography. Although the mileage restriction has since been eliminated, I have not been able to reopen those clinics. Once a rural clinic closes, staff disperse, financial stability is disrupted, and rebuilding becomes extremely difficult. Missouri has more than 100 counties with federally designated provider shortages. rural patients traveling long distances for care while trying to manage diabetes, heart disease, hypertension, and mental health conditions that require constant access. Patient safety is paramount. Decades of multiple peer-reviewed studies comparing nurse practitioners and physicians in primary care demonstrate comparable outcomes in quality, safety, and patient satisfaction. Our education pathways are different from physicians, but we are graduate prepared, nationally board certified, and regulated by the state. Scope of practice should reflect demonstrated competence and patient outcomes. States with full practice authority have higher concentration of nurse practitioners practicing in rural and shortage areas. The National Academy of Medicine has recommended removing unnecessary scope of practice barriers to improve access. More than half of our states have done so without evidence of reduced safety. Full practice authority does not eliminate collaboration. Healthcare is inherently collaborative. It prevents clinics from closing because of contractual technicalities unrelated to patient outcomes. Missouri's healthcare landscape today is not what it was 25 years ago. Rural shortages have increased, chronic disease burden has increased. Updating our regulatory structure is not abandoning safety. It is responding to today's access challenges. Since 2000, I have cared for Missouri families across generations. I am asking you to remove barriers that stand between them and timely care. At its core, this is about whether Missouri patients can access timely, consistent care in their own communities, while qualified professionals are allowed to practice to the full extent of their training and licensure. Thank you.
Thank you for your testimony. Where were the three places that had to close?
Boonville, Moberly, and Mexico.
Thank you. Any questions of this witness? Seeing none, thank you. Next, first person to testify in opposition to, please come forward. Make sure you state your name and have your witness form filled out, please.
Good morning. I'm George Hubble, an obstetrician gynecologist practicing in rural Missouri. I herald from the Kingdom of Callaway. I'm here to testify against Senate Bill 979 in behalf of the Missouri State Medical Association. As an aside, I have my practice, I was elbow to elbow with a nurse practitioner for the duration of my private practice for 3 decades. I found them invaluable, diligent, competent, and brought a lot to my practice. Interestingly enough, all 3 of them I queried as to whether they would want to practice independently. All vehemently said no. So I don't know that every APRN in the state truly wants to practice independently without collaborative backup. The way things are presented today is that this is by acclamation that the APRN organization would like to have independent authority. Secondly, we heard some testimony about cost, the cost of providing care. I think obviously the legislature is really tuned into cost. You're trying to cut costs at every corner. A large study demonstrated in a Mississippi multi-specialty clinic about 3 years ago. It was in rural Mississippi. They were having difficulty filling with attrition positions in that clinic, and so the manager, the business model was to fill them with PAs, physician assistants, and APRNs. Interestingly enough, the fallout from that in going from a total, again, a physician-backed kind of and run organization to that of management with mid-level providers was that that clinic obtained $28 million a year in revenues, more in revenues. I think that's again that's a tax consequence that's adding to a problem in our nation right now, with the price of health care being 19% of our GDP. Shortages exist in all Missouri counties for physicians, save one, Platte County. Interestingly enough, the studies that look at states who have given APRNs independent authority have not filled their void, have not gone rural. Nurses, by medical literature, would demonstrate the contrary, and that the fact that APRNs want to practice in urban areas or in the city.
That's your timer, but I'll give you a few seconds to wrap up.
Okay, well, in that case, I'm going to let my colleagues add the rest, and I will just say, in sum, for the reason I just presented, cost, safety, which I didn't get to touch, or quality, please don't take this state off the guardrails and allow independent practice.
Thank you for your testimony. Anyone, any questions of this witness? Thank you. Next person to testify in support of, please come forward.
Mr. Chair and members of the committee, thank you for hearing both of these bills today, and thank you to the sponsors for bringing these bills. My name is Jamie Kavanaugh. I'm an attorney with the Pacific Legal Foundation, and even though Pacific's in our name, we work in all 50 states. We work to defend Americans when their constitutional liberties are abused by the government, and we've won 18 cases at the U.S. Supreme Court and have enacted dozens of laws nationwide. One of the areas we work in is called opportunity, entrepreneurship and opportunity, and we want to make sure that people can work in the professions of their choosing, free from arbitrary government restrictions. So one of our clients you just heard from, Marcy Marcus, is an APRN here in Missouri who has been serving patients in Columbia for more than 3 decades, but has had to overcome many obstacles and close clinics because of the restrictive requirements here in Missouri. And we would love to see Marcy and all the other APRNs here in the state being able to spend 100% of their time with their patients and their clinics instead of having to be here, and also having to be involved in a lawsuit against the government to sue about the restrictive practices that are in place here in Missouri. So Pacific Legal Foundation believes that all healthcare providers should be free to practice to the full extent of their training, and collaborative practice agreements should be eliminated unless there's evidence of a real-world harm and a reason to keep them in place. And we simply don't see that. We've submitted written testimony to this committee as well, with several citations to academic peer-reviewed journal articles showing that the evidence points the other way. In the states that have loosened restrictions and given full practice authority to APRNs, we see positive outcomes. We see more access to care. There's several studies that show more access to care in rural areas. We see that, actually, this is a really interesting one, physician malpractice rates decreased by more than 20%, between 21 to 24%, when independent practice authority was introduced. This might be a function of competition, physicians having more competition and having better quality services. And there's several studies that show how costs go down when the APRN workforce grows. So again, we've heard that the state right now is losing APRNs to other states, and that's really a travesty that APRNs who want to be working today in Missouri have to go to Kansas or elsewhere just to do what they're trained to do. So we urge support for this bill.
Thank you for your testimony. Any questions from the committee? Thank you. Next person to testify in opposition to, please come forward.
Good morning. I appreciate the time to provide some testimony on behalf of these two bills. I promise I won't take my entire 3 minutes. I have a lot of information to leave for the committee. My name's Keith Ratcliffe. I've been a rural family physician for 37 years now. I was born in Missouri, trained in Missouri. I hope to finish practice and die in Missouri, but not anytime soon. These two bills I'm testifying in opposition to on behalf of the Missouri Academy of Family Physicians, 2,300 of your constituents who feel that there is some real danger in these bills. In particular, prescriptive authority for Schedule II amphetamines is not really a benign thought. These are dangerous drugs. They can be addicting if they're not prescribed correctly. They can cause great harm. We found that out with opiates 20 years ago, and we're still trying to correct that mess. Having more practitioners prescribing controlled substances is probably not a good idea. There's a reason they're controlled. We've already heard some of the fallacies that we hear every year in this regard. One of the big fallacies, of course, is that APRNs will help solve the rural family medicine and primary care crisis. This has been debunked time and time again. It's kind of like election fraud. I've included in the information scope of practice maps overlays of where nurse practitioners practice and physicians practice. As a matter of fact, a Board of Nursing study done just a year or so ago showed that in Missouri, only 17% of nurse practitioners actually practice in primary care settings, and only 5% of those are in rural areas. In my career, we've abolished geographic proximity. There's no longer an excuse that you have to be within 30 miles or 50 miles or 70 miles of your collaborating physician. That's gone. It's been gone. But yet we see no migration of nurse practitioners to our rural areas. You know, we really do have a rural primary care access crisis. That's very real. There are other solutions. The other fallacy is that this is the only solution to that problem. I can tell you we have, and again, we have a lot of information here for the committee to look at. We have 6 medical schools in Missouri, both allopathic and osteopathic schools. We have 1 campus from an international school. We train 4,500 medical students a year. We graduate 1,100 of those students. Unfortunately, most of those students have to go elsewhere for their residency training. So talk about a pipeline we've invested in that has to migrate to finish their training. That is the biggest barrier we have in Missouri. Now, I have to thank the Senate and the legislature for helping solve that problem with some of the appropriations for graduate medical education. Within the next 10 years, you will have been responsible for keeping 90 more physicians in Missouri that could have never trained here without that. We have 16 family medicine residencies. We train 350 family medicine physicians a year. Most of those stay in Missouri. The research has shown
That's your time. I'm going to give you a
Okay.
few seconds to wrap up, please.
Alrighty. 75% of those who train in Missouri stay in Missouri. So there's a lot of fallacies that have come around every year before the committee. Please look at the data on the overlay maps, and I think you'll see that it really is not the only issue out there. Thank you.
Thank you for your testimony. Any questions of this witness? Senator McCreery.
Yes, ma'am.
Speaking of fallacies, I just wanted to let my colleagues know and the audience know that on page 3 of the bill, lines 23 and 24, it specifically says Schedule II stimulants for behavioral health patients. So I just wanted, the way you presented that information about Schedule II is not accurate. Thank you.
Well, you're correct. Schedule II stimulants for mental health patients includes stimulants like Adderall, Ritalin, things that are quite dangerous in the wrong hands, and it's not a nuanced prescriptive authority. Is very complex, and I think don't think we want less experienced people providing those. But thank you for your
Well,
correction.
I would like to see all Missourians, no matter where they live, have access to behavioral health care. So that's why I wanted to make sure that that people knew I was comfortable with that. So thank you.
Thank you.
Any other questions of this witness? Next person to testify in support of, please come forward.
Thank you for this time, members of the Emerging Issues and Professional Registration Committee. My name is Dawn Pfeffer-Wright. I'm an advanced practice registered nurse of 25 years. I am a constituent of Senator Schroer, and I am the Director of Advanced Practice Providers at Barnes Jewish Hospital in St. Louis, Missouri. I am a representative of BJC Health, which many of you probably know provides world-class health care across the state of Missouri, with flagships in Kansas City as well as St. Louis. We also provide significant primary care throughout other access points across the the state, but we also have challenges getting our world-class specialty care into those affiliated clinics across the state. The restriction that we find in current practice is around the 1-month period in which the collaborating physician must practice with their APRM continuously in their settings before practicing independently, and also they must the collaborating physician must be present at least every 14 days. So it does limit our ability to put specialty APRNs outside of their areas where their collaborating physician is, despite the lifting of the restriction of the geographic location. We have APRNs throughout the BJC Health who are extraordinarily skilled in specialty practices such as oncology, cardiology, radiology, all of the ologies, and we would love to be able to support them across the entire state and not just in our flagship areas of St. Louis and Kansas City. Additionally, our academic centers are very dependent on APRNs. As many of you know, our academic centers are at capacity on a daily basis. APRNs play a significant role in providing the throughput of patients from their entry points into our hospitals to their discharge. But they also are recognizing how sick and acute our patients in our academic hospitals are. And we now realize we need much greater coverage of our very acute patients on nights and weekends. So getting our APRNs to be able to cover our nights and weekends to provide safe care 24/7 in our large academic institutions is very hard to accomplish with the current state that independent practice would resolve. The collaborating physicians must be with their APRNs continuously for 1 month before they can practice independently. So we cannot move them to nights, which is our greatest needs, until that is met. And then the collaborating physician must be present every 14 days. Most of our collaborating physicians do not want to work nights and weekends, so it really limits our ability to cover those. So those are our high points there, but I would just like you to empower all of our APRNs in the state of Missouri to provide that world-class care across the entire state.
Thank you for your testimony. Any questions of this witness? Seeing none, thank you.
Thank you.
Next person to testify in opposition to, please come forward.
My name is Dr. Elizabeth Lucor. Thank you to the committee for this conversation today. I am a family practice physician going on 18 years in practice, full scope family medicine with obstetrics, and 15 years of those years were spent in Monette, Missouri, so a town of about 9,000. I'm hearing just wonderful conversation today, mostly focusing on logistical concerns, cost measures, and I'd like to speak to patient safety and quality of care, because I think at the end of the day, that's what this really comes down to. Everyone in this room cares about patient care, patient safety, good medicine provided for citizens of Missouri, and that is a passion of mine as well. So someone earlier said that we need to allow everyone to practice to the full extent of their training, and I think that's a great point. Nurse practitioners come out with those 2,000 hours. Family physicians range between 12,000 and 15,000 hours. So the difference of 1 to 2 years versus 7 years, maybe even plus. So I think as we're as you are considering legislation, remembering that we not only have wonderful experienced nurse practitioners with 20 plus years of experience, we also have brand new graduates who have less than 5 years of training, 2,000 hours. And so remembering that all legislation must apply equally to all of those practitioners. I would just tell a small story. I work in an express care shifts at times, and saw a person with an ongoing concern. She had been seen the week before for what was diagnosed as a rash, and she was given a steroid pill. That steroid pill was not helpful to her, and she returned. What I saw in the exam room was florid psoriasis. It would take several years to get to that severe point of discomfort and issue for her, psoriasis across her body. And I was able to start her on new medication. When I used the word psoriasis, that was a surprise to her. She hadn't heard that. When I reviewed the note of the nurse practitioner who I work with regularly, I'm not her collaborating physician, but that was an opportunity for me to talk with that practitioner and give her some advice. That's what comes from a collaborative physician nurse practitioner relationship, where there's opportunity for education, engagement, making sure that people who have a shorter term of in book training are then ready to take care of real life people. So I think we need to remember that this is not just a turf war or a degree bias. I'm not in favor of first-year residents practicing medicine on their own either. There are legislative actions right now in the state of Missouri to limit that as well. So it's nothing against nurse practitioners. I think the number of hours of training prepare a person to do a good job. Part of my job is to know what I don't know. A good physician should know what she doesn't know and go find out more. We should always be learning. It is very hard to know what you don't know when you're new. So again, legislation needs to be relevant to those new nurse practitioners.
That's your time, If you could wrap up, please.
Thank you. I am aware that I am required to have ongoing CME to allow me to be knowledgeable and safe in the prescribing of Schedule II drugs. It's concerning to me that people with less regulation would be allowed to do the same. And if you review the data and decide that you support these bills, I would ask you to consider bringing those nurse practitioners under the Board of Healing Arts with the same legislative accountability and responsibility that physicians hold, or increase the hours to 10,000. Thank you.
Thank you for your testimony. Any questions of this witness? Seeing none, next person to testify in support of, please.
Ladies first. Thank you. Good morning, Mr. Chair, distinguished senators of the committee. My name is Matthew Dowd, and I am the political director for the International Association of Firefighters, Local Number 42 in Kansas City. We represent approximately 1,800 members through 14 different shops, including both a large urban fire department as well as smaller municipal and suburban fire departments, rural fire districts, as well as a rural EMS district. You might ask why a firefighter has crossed the state today to speak on this issue. Knowing that I joined an inherently dangerous job when I joined the fire department, what I was not prepared for was the behavioral health issues that face first responders in our state. PTSD is a real thing, and unfortunately it's something that victimizes a lot of the people in my profession. I was injured severely in the line of duty. I spent 2 years in and out of a hospital receiving surgeries to get myself back up on my feet. What I didn't anticipate was PTSD hitting me as hard as it did. I've experienced the full gambit and range of what PTSD can do to a first responder and a firefighter. I've experienced flashbacks in real time, experiencing the worst calls I've ever experienced. I've experienced terrible, horrible nightmares. I've experienced panic attacks, night terrors, the whole list. When this happened to me, I didn't know what to do. I was at a loss, guys. And many first responders in this state feel the same way. Getting to the healthcare professionals that can help mitigate these issues is paramount for firefighters, paramedics, and EMTs in this state. And the reality is there are not enough service providers in this state to meet the demand. And it's a terrifying thing being in that situation when you have to wait, in my case, 3, almost 4 weeks to get to a psychiatrist to start that level of care and get prescribed the necessary medications you need to start mitigating this terrible experience. Empowering APRNs to have the ability to start prescribing these drugs very well could help the doctors and the psychiatrists open up their schedules, open up their time and their bandwidth to start treating the professional folks, our paramedics, our firefighters, and EMTs that service the citizens of this state to get the care they need in their most desperate hours. It is not unusual for firefighters, EMTs, and paramedics from across the state to wait 3 to 4 weeks to get into a service provider, sometimes up to 3 to 4 months. And I know I'm running up on my time. Freeing up the ability for these doctors and psychiatrists to have the help of APRNs to start to take that weight off their shoulders will grant them the ability and the time to start treating our first responders who desperately need it. It's something I've experienced, I wouldn't wish on my worst enemy, and we just need your help. And if this bill will give them the ability to start opening up more time to see our men and women that serve us, so much the better. Thank you for your time. Thank you for your consideration, and thank you everything you guys do for our great state.
Thank you for your testimony. Do you support the full scope of the expansion or just the?
Yeah, I support the full scope. Anything we can do to make sure we can continue to get our first responders in and treated and taking the weight off the doctors so they can treat more patients or so our members can be seen by APRNs, so much the better.
Okay, thank you. Any questions of this witness? Seeing none, thank you.
Thank you.
Next person to testify in opposition to, please.
I'm Brian Biggers. I'm a breast surgical oncologist and general surgeon from Springfield, Missouri. I'm also the current president of the Missouri State Medical Association. You know, we are told basically that, oh, you know, we don't like the nurses or we're going to be against this bill. It has nothing to do with that. I personally have a PA. I worked closely with nurse practitioners over the years. I used to do trauma. I even talked to two of them 2 or 3 weeks ago about this very issue, none of which went into independent practice. This job is routine until it's not. Our job is basically to know when it's not routine. You know, we want to talk about basically, you know, sorry, but it's basically with, you know, we don't have enough medical doctors that are coming out. That's not true. University of Missouri is going to open a 4-year campus in Springfield. That's 32 medical students per year. We're expanding residency programs in Springfield, internal medicine and in surgery and ENT and other as well. So we are expanding access to care. You know, from a personal perspective, you know, as a oncologist, you know, I personally have witnessed, you know, misses, you know, in, you know, rural, with rural patients with missed cancers, missed disease progression. We don't have a decrease in healthcare costs associated with scope expansion. Actually, we have the opposite. We have more tests that are being offered. We have more referrals to specialists. You know, from a perspective of an oncologist, more, you know, radiological tests we order. You know, it's estimated 35% of all cancers across the board is medical radiation or radiation we give patients. So those kind of things are important when we talk about the safety of our patients. It's not just about a scope issue, it's about giving quality care. And I personally, like I said, I work very closely with extenders. My PA is wonderful, and I work very close with nurse practitioners. A lot of them have my cell phone. They call me all the time for advice. But we don't advocate for independent practice.
Thank you for your testimony. Any questions of this witness? Seeing none, thank you. Next person to testify in support of, please come forward.
Morning, Senators. Thank you for allowing me to say a few words. My name is Jim Wallace. I'm born and raised in St. Charles County, Missouri. Live in Lincoln County, Missouri. Currently, I've worked as a not-for-profit director of mental health and substance use services for the past 35 years in the state of Missouri. At one point in time, mental health and substance use was very siloed. Thank goodness, over the last 10, 15 years, we've truly embraced integrated care, which now we're able to employ advanced practice nurses and have medical doctors on staff that continue the life of the individuals we serve and making it better for all. I really I'm not a nurse. I don't play one on TV, but I'm a huge nurse advocate. And where I got my start, even though I've been around 35 years, was in 2019 we had some funding to build a program in Jefferson County, Missouri, which we called Project Access, and it was mental health, substance use services, school-based counseling, and part of that practice was hiring a full-time advanced practice nurse and a medical assistant, and I struck out. I struck out to the point where I thought, well, we could not find a collaborating physician for a nurse, and we were about ready to kind of give up on that piece of the business. And then, lo and behold, we had a global pandemic, and restrictions that were once in place were removed. And for the last for the next 5 years, we were able to serve individuals, serve them where there was 6 to 9 month waits. Those waits were a couple of weeks, and I believe lives were saved. The pandemic went away, the restrictions came back. We have a great collaborating physician now, but we have lots of restrictions. All I want to point out is that 6 of the 7 states that are contiguous to Missouri have either transitioned to practice or full practice authority. Some of those states are blue states. In Illinois, we have 12 collaborating nurse practitioners, but in some states that are red, it just doesn't matter. And access to care is better, and lives are saved because of it. There's lots of great information from the Missouri Nurses Association, the American Association of Nurse Practitioners, and I'm a true believer, even though I'm not a nurse, and that these bills will save lives, and I'm a full supporter. Thank you.
Thank you for your testimony. Any questions of this witness? Seeing none, next person to testify in opposition to, please come forwards.
Hello, everyone. I'm Jay Devnini. I'm a resident physician in internal medicine and pediatrics in the city of Kansas City. I trained in medical school at the University of Missouri Columbia in the cities of Columbia, Sedalia, Marshall, and Springfield. I am a member of the Missouri State Medical Association as well, speaking on behalf of the association. So I think everyone in this room agrees that there is a healthcare crisis here, a healthcare access crisis here in the state of Missouri. And I think we all agree that there needs to be solutions to this problem. Where we disagree is what that solution is. Our wonderful senators who introduced this bill pointed out that the restrictive rules on nurse practitioners' scope of practice is driving nurse practitioners away from the state. While that may be true, what we're maybe failing to realize here is that the more you expand the scope of practice of nurse practitioners, the more you drive physicians away from the state. So Dr. Ratcliffe eloquently pointed out that we have a residency slot shortage, a massive shortage in the state of Missouri. And that's really the major problem that's driving this healthcare access shortage, and that's really where the solutions need to come. We're graduating twice as many medical students from Missouri medical schools as we have residency training slots in the state of Missouri. Even if every single medical school graduate from a Missouri medical school tried to stay in the state of Missouri, only half of them actually could because of the number of slots we have. That's the problem, and that's where the solution needs to come. One of our nurse practitioner colleagues pointed out that, we need nurse practitioners to cover weekends and night shifts and less desirable shifts like that. You know who else covers those shifts? Resident physicians. We need to invest in our residency slots and our resident physicians to cover those things, who will eventually become full-fledged board-certified physicians who have earned the full scope of practice. That's where our times and efforts needs to be spent. That's where the solutions are, not in expanding the scope of practice of nurse practitioners to have similar rights and privileges with less training. Thank you.
Thank you for your testimony. Anyone questions for this witness? Seeing none, next person to testify in support of, please come forwards.
Good morning. How are the members of the committee today? Thank you very much for your time today, and I am sitting strangely, so let me reposition myself here. My name is Karen White. I am the CEO of one of the largest rural federally qualified health centers in Missouri. I proudly serve 7 of the most beautiful but rural counties within the state, and those are Butler, Carter, Iron, Reynolds, Ripley, and Shannon and Wayne counties. They are beautiful. However, we do face a crisis, and we've talked about that. You've heard enough, I think, from the ones before me, that we do have an access crisis within rural health. And so I come before you today to just give you my perspective and our experience with APRNs. We employ several different types of APRNs within Missouri Highlands Healthcare, the traditional family nurse practitioners, certified nurse midwives, as well as the psychiatric nurse practitioners. We address everything at Missouri Highlands, from primary care to pediatrics to women's health, substance use disorder, and of course dental. But we're not here today to talk about the dental crisis. We're just here to talk about the medical and behavioral health. Within Missouri Highlands, the service area of Missouri Highlands, of the 7 counties, Butler County is the only county that has full access 7 days a week to physician coverage. My other counties, we stagger the physician. It's not a great practice. They're shared among different counties, different communities, and they're never in a county 7 days a week or even 5 days a week. So we struggle with that. Within 2 of those 7 counties, there are no physicians within those counties, and that is Shannon and Carter. So if any of the wonderful residents or physicians sitting behind me would like to relocate, come talk to me. We have tried over the years different recruiting ideas, loan repayment, paying $50,000 to $75,000 more than my urban counterparts to get physicians into rural areas. And it just does not work. They come for a while and then they return to urban settings. And I know that the issue has been presented that nurse practitioners only practice where physicians do. And that is not the case in our area. Our nurse practitioners practice because no one else cares enough to be there. Yes, traditionally, nurse practitioners are homegrown, so to speak. They don't.
That's your timer, so I'm going to give you a few
Okay.
seconds to wrap up,
Thank
please.
you. They don't leave the area. They care about their patients. Not saying that physicians don't care, but they are invested in the people that they see at the schools. They are invested in the people that they see at church, at the grocery store. They want to do better for the communities that raised them. So I ask you to work towards removing the restrictions, allowing us to engage a broader workforce to fix rural health access issues. Thank you.
Thank you for your testimony. Any questions of this witness? Seeing none, next person to testify in opposition to, please come forwards.
Hello. My name is Samantha DeLuca, and I speak on behalf of both myself as a lifelong Missourian as well as a student representative of the Missouri Association of Osteopathic Physicians and Surgeons and the Missouri State Medical Association. I urge my congressmen to oppose Senate Bills 979 and 1016. I am a fourth-year medical student. I was born and raised in northeastern Missouri, and I am the daughter of factory workers and farmers. I'll be the first in my family to graduate college and the first to go to medical school. I say that because my path to medicine wasn't direct, it wasn't straight. I was a social worker before I would be a clinician. As a social worker, I saw an intense need. There was just an expansive, heartbreaking need for mental health care in our state. And so I came back. I came back to do medical school with the intent to go into psychiatry. That is all to say that these bills are very near and dear to the issues that I've championed, both as a social worker and as a medical student. I know the chasm before us. I was the patient waiting for long times to see a psychiatrist when I was a child. I know that. But these bills, while seeking to address the issues, will push us in the wrong direction. These bills will allow advanced practice registered nurses to prescribe Schedule II stimulants for things like behavioral disorders. These include methylphenidate formulations and amphetamine-based medications, which are often used in ADHD and in narcolepsy. These medications work. We know that from more than 80 years of clinical use, but no medication comes without its concerns. And without even addressing the abuse potential and the dependence potential that these medications have, I would like us to note that during stimulant treatment, 2.8% of patients will develop psychotic disorders, and 3.7% of patients will develop a mania consistent with bipolar disorder. I don't want us to be scared of using these medications, but I want us to be aware of the concerns that they have and to note that they must be prescribed and carefully monitored by physicians who are trained in these adverse effects and understanding the way they impact the patient, when to intervene, and how to intervene. Patients expect that these medications are being prescribed and directly monitored by physicians. I've given up the last decade of my life, gratefully, gladly, and I would do it again, to be a physician for my patients and my fellow Missourians. I will nearly amass 16,000 hours by the time I am done with my residency training. On the other hand, ARPNs typically hold a master's, have 6 years of education, and will amass around 700 hours of practice. This is very different. There's a place for all providers. With the supervision of a physician, APRNs excel, and we can keep patients cared for and safe. I worry that these bills prioritize this antiquated notion of any care is better than no care, and Missourians deserve better. If we want to eliminate barriers to care, there are feasible solutions. Expanding residency spots, as noted before.
That's your timer. If you could kind of wrap up now, please.
Yes, sir. Building pipeline programs like the National Health Service Corps, of which I am a part of, and encouraging young rural Missourians like myself to consider medicine. These bills do none of these things, and I believe they will only hurt Missouri patients. Thank you.
Thank you for your testimony. Any questions of this witness? Seeing none, next person to testify in support of, please come forwards. Make sure you have your witness form filled out with both bills that you're testifying on. Numbers.
Thank you, Mr. Chairman and members of the committee. Samuel Lee, registered lobbyist with Campaign Life Missouri, to go on record in support of both Senate Bill 979 and Senate Bill 1016, and very grateful for our two senators for sponsoring this legislation and for this committee hearing this. This is legislation. This is an area that the pro-life movement has not been involved with before. I spoke to a group last November of pregnancy centers and maternity homes, a statewide coalition. There was a meeting, a conference, and I asked them, what's the one thing you want to see the pro-life movement pass next year? And to my great surprise, it was this legislation. I had a nurse from Southwest Missouri, an APRN, who assists at one of the pregnancy centers there. And she told me, and everyone in that area that I was talking to nodded their head, there's no OBGYN here, and I cannot get into a collaborative practice arrangement with an OBGYN to serve these women who are coming in at the pregnancy center that she was volunteering and working at to help these women. And I was shocked. I sort of had heard this, and everyone else nodded in the rural parts of the state. We have a maternity care desert crisis in Missouri. According to the most recent March of Dimes data, 51.6% of Missouri counties are classified as maternity care deserts compared to just 35.1% nationally. And a maternity care desert is defined as a county without a single hospital or a birthing center that offers obstetric care and 0 obstetric clinicians within that county. Over half of our counties are in that situation. So these women, whether they're going to the pregnancy center or they're going to the food bank, wherever they're going to their local church, cannot get the care they need because even the nurses who are certified nurse midwives, of course, who are APRNs, that's a subset of APRNs, cannot help them because they cannot get into collaborative practice agreements. Mr. Chairman, I urge this committee to strongly consider passing this legislation. And I'll just add one thing that has not been discussed yet, and that is the Federal Rural Transformation Program funding. We have a baseline, like all states do, of a certain amount of money, but if this type of legislation passes this year, then our Department of Social Services and the governor's office can go back to the feds and say, you know what, we are increasing access here in Missouri. Please send us more federal funds, and that'll free up general revenue for all sorts of things, including caring for disabled people in Missouri. Thank you, Mr. Chairman.
Thank you for your testimony. Any questions of this witness? Senator McCreery.
Sam, I just wanted to, first of all, just say thank you. I appreciate your consistency in this building through the years of kind of wanting to provide care for all people, and I just really appreciate you speaking out on this. You know, I do think that, that there are a lot of families that want to grow, but when you're in a maternity healthcare desert, it would really, I know it would make me think twice about wanting to be pregnant and go through, the 40 weeks and then, all the concerns that happen. And of course, we all know that for the year after a woman gives birth, she's also at increased risk of death. So I just really appreciate your consistency in speaking up for these things.
Thank you, Senator.
Thank you, Mr. Chairman. Sam, how much money are we talking about from the feds?
I do not know. That's a great question. I've asked someone in the governor's office about that, just sort of general ballpark, and they didn't have a figure.
Are we talking 10 million bucks? We talking $1 billion?
Millions, but I do not
Tens
know.
of millions?
I do not
Hundreds
know.
of millions?
I
No idea.
I wish I could answer that. I'd be speculating.
Seems like a pertinent, and maybe this is to the bill sponsors, but it seems like a pertinent conversation to have, the positive nature as the state is looking at decreasing income tax by $9 billion, that maybe we should have a conversation about legislation like this and the amount of federal reimbursement that could bring into the rural parts of the state.
Senator, I couldn't agree with you more. I simply do not know the answer.
All right. Thanks, Sam.
Mr. Chairman, I'm going to leave my written testimony, but I've already submitted online forms.
Any other questions of this witness? Seeing none, next person to testify in opposition to, please come forwards.
Ready? Thank you, Senator. My name is Rachel Kylo. I'm a physician. I'm a board-certified dermatologist, and my husband and I started a practice about 6 years ago that has 4 dermatology locations, 3 of which serve primarily rural areas, in Arnold, in St. Charles, and in Rolla. Our practice employs and uses non-physician practitioners, but within a physician-led environment, and we care too. We care about rural patients. Unfortunately, we have witnessed some subpar care that has been provided by unsupervised NPs in neighboring states. I'd like to start with a patient story. I'll call him Joe. That's not his real name, but Joe. He was diagnosed with a nurse practitioner in Illinois as psoriasis on his arms for years. He was put through extensive laser treatments at the nurse practitioner's office and prescribed expensive biologic medicines to the tune of tens of thousands of dollars. Unfortunately, the diagnosis was not correct, and when he sought a second opinion after a year of no improvement with my husband, who's a general dermatologist at our practice, he was diagnosed with the correct diagnosis, which was a precancerous condition called actinic keratoses, which eventually progressed to a squamous cell skin cancer that I treated, I'm a Mohs surgeon, on the gentleman's arm. He was prescribed the appropriate treatment and has gotten much, much, much better, but unfortunately went misdiagnosed for years. This story is not unique. There are several others, but I'll go shift to talking more about data. So data shows that granting unsupervised practice of medicine does not lead to an increase in rural care. Multiple states, Washington and Oregon in particular, have had unsupervised practice of medicine for APRNs for decades, and they still face persistent rural health care issues, just like Missouri. More recently, Florida granted unsupervised practice of medicine to APRNs. They put guardrails on it. They limited the scope of practice to only primary care. But just 2 years later, a study has shown that fully half of the autonomous nurse practitioners in the state of Florida are not practicing in primary care. And half of those, so 25%, are practicing in aesthetics and med spas. Unfortunately, these unsupervised autonomous nurse practitioners are not flocking to provide behavioral mental health care. So please protect patient safety, preserve physician-led care. Thank you.
Thank you for your testimony. Any questions of this witness? Thank you. Next person to testify in support of, please.
Good morning, Mr. Chairman, members of the committee. My name is Bill Bates. I'm CEO of Leading Age Missouri, which is an organization and a membership organization that represents about 200 senior living and health care providers across the state of Missouri. I am here in support of Senate Bill 979 and Senate Bill 1016. When I ask my members what their biggest challenge is, the answer I consistently get is attracting and retaining qualified caregivers, especially nurses. There is compelling data to support this challenge. Now, our members need nurses, and we need APRNs, and we need them for the care that they provide and the leadership in our senior living communities that they can provide. And the state must do all it can to help us attract nurses and APRNs to Missouri. APRNs are trained in primary care. They also have the opportunity to get additional training in geriatric care. I will tell you, if you don't already know, that there is a lack of primary care physicians in Missouri and nationwide, that there is an even higher lack of geriatricians in this state and nationwide. And the situation is going to get worse before it gets better. So we need the care with the experience that they bring. They don't want to be doctors, but they want to deliver the care that they are trained as graduate students and through an extensive training program to provide in both primary and geriatric care. It will help our senior care communities throughout the state of Missouri. And we will attract more to Missouri if we can reduce the barriers to entry to this practice. And more APRNs will be better care for our seniors. And I need to also add that they will deliver care outside of my member communities. I represent home care organizations as well. And if you don't know this, there are not going to be enough brick and mortar places for the baby boom generation to reside in their older years. We just aren't going to develop that many places. We're going to have to age in place, and we're going to need care in our homes where we live. We support the legislation. We appreciate your consideration. I'd be happy to take any questions.
Thank you for your testimony. Any questions of this witness? Thank you. Next person to testify in opposition to. How many more people do we have to testify in support of? In opposition to? Okay, thank you. Proceed when you're ready.
Hello, I'm Dr. Emily George. I'm a pediatrician here in Jefferson City with JC Peds. I did my training at St. Louis Children's Hospital, and I was working at JCMG for several years, moved down to Texas, and then just came back to Jeff City about 4 months ago. I think it's important as we talk about access to care to also talk about quality of care. I've learned during my 12 years of providing care to children that medicine is best practice collaborating with all types of other providers, both medical specialists, physicians, and APRNs. I'm currently working with a new nurse practitioner who just graduated and completed her testing, and she and I have been working collaboratively for the last 4 months, and she continues to need daily oversight and instruction to provide quality care to our patients. And we're not just talking about complicated things, we're talking about simple things like recognizing when a child is wheezing, recognizing when it's an ear infection versus just fluid behind the ear, so appropriately prescribing of antibiotics. As many of the other physicians have said, it's an important part of practicing medicine of recognizing what you don't know and when you need to ask for help. In these bills, it says that 2,000 hours is enough for a nurse practitioner to work without the collaboration of a physician, and that's less than 1 year of practice. It doesn't specify what the specialty of that practice is or what the APRN would be able to practice independently. Since moving back to Jefferson City this fall, I've also had an adolescent mental health patient who was seeing a nurse practitioner for care. She was being prescribed multiple medications, including a stimulant, at subtherapeutic levels. She was practicing self-harm and had suicidal ideation. We've adjusted her medication, and I'm happy to say she is now doing better, but she was receiving care from someone who was not providing appropriate and safe care. I also have 3 sons who are all treated with stimulants. And in the last decade, stimulant prescribing has increased by over 50%, and a lot of that prescribing is being done by nurse practitioner. I've seen both as a parent and as a prescriber that I've had patients who have had difficulty finding medications due to intermittent shortages and the increased prescribing. So creating access doesn't necessarily also provide access to providers, doesn't always provide access to care. I've also prescribed a variety of stimulant medications to patients and have sometimes been surprised by the adverse effects that they've had, including hallucinations, tics, pathological lying, and low blood counts, putting them at risk for infection.
All of medicine is collaborative practice, and being able to ask for help and knowing who to ask for help is important to provide quality care. We are not asking for APRNs to stop practicing medicine. We're standing up for the importance of physicians as leaders of the healthcare team.
Thank you for coming back to Missouri, and thank you for offering your services to Missouri. Any questions of this witness? Thank you again. Next person to testify in support of.
Mr. Chairman, members of the committee, my name is Jay Hardenbrook. I'm the Advocacy Director for AARP here in the state of Missouri. We're a social change organization for the 50-plus with a membership of just over 750,000 in the state of Missouri alone. I think it's already been pointed out that a lot of people, after the pandemic restrictions basically went back in, a lot of people have lost care. We hear from our members, especially in rural areas where we've had a problem with hospitals closing, but we've had an even bigger problem with clinics closing. This type of legislation will make it possible to reopen some of those. They opened during the pandemic. They could certainly open again. Plus, I think the point was already made, but as we have a quickly aging state, we're aging faster than a lot of the states around us. Our citizens are going to need access to APRNs. We're going to need APRNs who will be willing to do house calls as people age in their homes where they want to stay. So we have supported increasing the scope of practice for APRNs for many, many years. We think it's vitally important now, especially given the situation that we're facing with a healthcare crisis throughout rural Missouri.
Thank you for your testimony. Any questions of this witness?
Thank you so much.
Seeing none, thank you. Next person to testify in opposition to, please come forward. Again, have your witness form filled out, please, and speak into the mic. Next person to testify in support of, please come forwards. Remember, you have 3 minutes speaking to the mic, and make sure you have your witness form filled out, please.
Hello. My name is Sheila Armbruster, and I've been around and up here a lot of years. I've been an RN for 40 years. During my just RN time, I went forward and got a geriatric certification as well because I knew our population was aging. I was seeing it. I'm it now. I'll be 70 this year, and mostly I'm just tired. And I'm just going to give my testimony here from my heart. I have been a nurse practitioner for 12 years. I haven't heard much today about southeast Missouri. I'm talking the southeast. We have nothing down there. In fact, I have had 4 clinics. 3 of those have closed by attrition. And I've had several of my collaborators retire. At this point, I have 1 open in Sykeston, Missouri, and I'm actually doing some primary care there, charging cash pay because I don't have staff to do the billing. And so we're just doing cash pay, $100 every 3 months. If they can't pay, I see them anyway. I have also been praying, and I am a Christian. I'm not afraid of that, to tell you that. I've been praying, and I asked God to help me, and I've opened a free clinic in Lilburn, Missouri. There are no providers there. There are no transportation help there. You can have a Medicaid transport try to pick up a patient 2 or 3 times, and it might be something that they need a cast removed. I can't do that in my office, and I don't have the equipment to do any of it. I have also, in the last 6 weeks, diagnosed 3 OSAs, that means obstructive sleep apneas, where people are dropping in their 70s. At night. I've also sent them to specialists to be treated. I have found 2 thyroid cancers, and these people were seeing no one. Well, one of them had seen 3 physicians up in St. Louis, and then she came to me down there, and I was actually just visiting with her and saw all of her symptoms, and I'm thinking, someone's missing something here. And so I started drawing labs and realized this is abnormal center for imaging, and she's already had the thyroid removed, lymph nodes involved, having the radioactive iodine treatment. The other is has cancer. She's having another biopsy today. These people, you may think they're not important, but I'm going to tell you as an older woman, if we don't treat the poor people, the children, and the people that are so messed up with methamphetamine and different
I'm
things
going
like
to ask
that.
you, that's a timer, so you got a few seconds to close, please.
Okay. That if we don't treat these people, we will definitely pay for it as a society. So I'm begging for us to be set free. I'm right now paying my collaborator out of my Social Security check. And I've asked him to donate that because he has 3 Porsche. And he says, I think you need to go to work at a hospital so you can make some money. I'm not worried about making money. I'm too old. I just want people to be treated, and that's what I'm on the planet for. And I'm asking help. I'm not against physicians. I refer every day, and I collaborate with them. I have their numbers on my phone. I talk with them every day, the people I'm referring to them or their nurse practitioners. So my collaborators are my specialist, not my collaborating physician.
Thank you for your testimony. Any questions of this with Senator McCreery?
Thank you for everything you're doing. As you were describing some of these scenarios, it sounds like a third world country, quite honestly, and it's unacceptable, quite honestly. So you talked about paying to collaborate. So is that an annual, like, you know,
It's
is
every
it,
month. Every 4 weeks it comes due, just like my rent and my utilities.
is it like $100
It's
or
$650
every month?
every month. And that doesn't sound like much.
No,
but
that's
when
a-
you're paying out of a Social Security check, let me tell you,
Yeah.
I've always worked independently because the corporations limit the time limits that a patient can be seen from 8 to 20 minutes. I've talked to them.
Mhm.
I know these are nurse practitioners. 20 minutes for GI. I have 10 to 12 systems. I can't do that in 8 minutes, and I'm not going to do it. I'm going to treat people, and I'm going to trust God to meet my needs. But I have a daughter that's in nurse practitioner school. I have a granddaughter in nursing, and I'm going to supplement. They're going to take my place because I'm tired.
Mhm.
And I see people in their home right now that are on hospice, but I go see them anyway because I've treated them for 12 years. And I will be with them when they die. That's exactly how I feel, and I'm going to tell you I need help. I am begging. I am too old to do this, to drive up here all the time, every week, put my patients off, and then have to work at night. I'm exhausted, and I am going to do it, though, until I die if I have to, because I need some help. I'm asking for help. I want doctors. I don't care. I do not care. I just need help, and I need someone that will help these people.
Very good. Thank you for being here this morning.
Any other questions of this witness? Senator Huff.
Thank you. And it may not be a fair question to ask you, but I'll ask anyway. And if you don't know the answer, that's fine. Who sets the rate of that collaborative practice agreement?
He
with
wanted
the physician?
$850, and I said, I don't have that much.
So is it up? I guess my question would be: Is it up to the collaborating
Yes, they
physician
each set
to
their
the
own
rate?
cost,
Okay.
yes.
Okay.
Yes.
Thank you.
Thank you.
Any other questions of this witness?
I'm
Thank you.
sorry.
Next person to testify in opposition to, support of, please come forwards.
Mr. Chairman, members of the committee, Jamie Murphy on behalf of the Missouri Hospital Association in support of Senate Bill 979, Senate Bill 1016. Missouri Hospital Association supports these bills, but we have a caveat. We like 4,000 hours of collaborating practice before you transition to practice, not the 2,000s in the bill. So as long as there are 4,000, we're on support. When I was looking at where physicians in Missouri live, I had the Department of Professional Registration. They pulled where DOs and MDs physically that have licenses live. 78% of them live in St. Louis, Kansas City, Springfield, and Columbia. That's about 66% of the state's population. So that means 22% of licensed physicians manage the 34% of the remaining population of the state over a vastly greater land mass. 48% of Missouri counties have less than 10 physicians living in them. So we know that there's a problem in rural Missouri when it comes to physicians living there. The solution to that problem would be to recruit kids from those communities to go to medical school. Well, there's a little bit of a problem with that right now. I think there was a big debate over whether nurses were professional licensed or not, but that was in the context of how much student loans they can qualify for. The federal government caps student loans, so it's $200,000 for professional degrees and $100,000 for other degrees. So what you're going to find is a kid from Ladue whose mom's a physician and dad's a lawyer, they're going to be able to get the capital to go to medical school. You're going to find a kid from rural Missouri, dad's a farmer, mom's a school teacher. They're not going to be able to get the funds to go to that school. That means we're going to have a future here in about 5 to 7 years where we're getting less kids from rural Missouri, where we need providers the most, being able to go to medical school and return to those communities. So Missouri needs to plan, and this bill would be one part of the plan on how we're going to address the shortfall of care in those communities. And I think that's why we're in support. Happy to answer any questions.
Thank you for your testimony. Any questions of this witness? Seeing none, thank you. Next person to testify in support of, please come forward.
Good morning. Thank you for your patience, all of you. My name is John Armbruster. I'm a nurse practitioner. I've been a nurse practitioner for 12 years. We have heard repeatedly about the shortages in Missouri. Oh, I'm sorry. We've heard repeatedly about the shortages in Missouri. We've had a long-term problem with... I got to be closer. Am I okay? I'll just sit right here. All right. Thank you, sir. So Missouri's faced a long-term problem with primary care for decades. Missouri in 2014 ranked 37th nationally and slipped to 40th place nationally in 2017. 2025, we have a rank of 43 in the nation, with poor marks in health care for our prevention, treatment, and just overall performance. HIPSA, of course, reported shortages in 113 of 114 counties. In 114 counties, out of 114 counties, we have a shortage of mental health. And we've heard from OB-GYN, gee, how do we get people into the rural health care place? So I heard a physician talk about residency, and I like that because the residency, I've included here a comparison between educations in Missouri for medical doctors and for nurse practitioners, and I will leave that here. We see a lot of similarities, actually. One of the similarities is that they talk a lot about the same courses. They have the same textbooks, basically. And the interesting thing is that nurse practitioners start 4 years earlier in their training with patients. So until somebody is in medical school, there is not a program that they're in front of. So I wanted to point that out. So it seems like residency is where things are talked about, and transition to practice fulfills that. We don't need a special residency program when we in fact have the work-based program. I worked with a physician in ER here several years ago. His motto was see one, do one, teach one. So in rural Missouri, we are just definitely grabbing at straws to try to provide care for the people that are out there. We need time. We don't need more corporate clinics that go out there and put you on a treadmill. I know it sounds like I'm blaming the clinics. I'm not. I would say the insurance companies, but it's just kind of a mess. That's why we have gone to eliminating all of that and taking cash only in our clinics.
That's your time. I'll give you a few seconds to close
all
up,
right.
please.
So in summary, I would say that I'm in support of this bill. I want to thank you for your time and your patience today.
Any questions of this witness? Thank you for testifying. Next person to testify in support of, please come forward.
Good morning. Heidi Lucas. I'm the Executive Director of the Missouri Rural Health Association, and we're here in support of both of these bills. So, advanced practice registered nurses they're not a future solution for rural Missouri. They're the current backbone of care in our rural communities. In many of our small towns, the nurse practitioners are the primary care provider. They manage chronic diseases, provide well child visits, treat behavioral health problems, respond to urgent needs, and keep patients out of already strained emergency departments. They live in these communities. They're often from these communities. They understand their patients, and they're more likely to stay long term. When we create policies that allow APRNs to practice to the full extent of their education and training, we're not replacing physicians, we're expanding capacity. In rural Missouri, healthcare is a team sport, and by removing unnecessary barriers, this helps our rural providers recruit more quickly, reduces administrative burdens that make practices harder to sustain, and allows experienced clinicians to serve where they are needed. So I'm happy to answer any questions that the committee has.
Thank you for your testimony. Any questions of this witness? Seeing none, thank you. Next person to testify in support of, please come forward.
Thank you, Mr. Chair, members of the committee. Garrett Webb here on behalf of the National Council of State Boards of Nursing and Phoenix Home and Hospice Care in support of both bills. Don't want to belabor the point, but echo all of the sentiment already.
Thank you for your testimony. Any questions of this witness? Seeing none, next person to testify in support of, please come forward.
Mr. Chairman, members of the committee, Derek Leffert, CEO of the Association of Missouri Nurse Practitioners, going on record in support of this bill. Just a couple of points I wanted to make real quick. If the sky was going to fall, it would have fallen in any of the other 36 states where this is allowed, and it hasn't. And so I think that's evidence enough that this public policy is long overdue to be revised and repealed. And then secondary to that, we hear a lot of comments and concerns about APRNs and how they're not as well educated as physicians. And while the education may be different, I would say that APRNs are going to stay in their lane, much like any other professionally licensed occupation. If they're licensed, they have a specific thing that they are permitted to do. And if they go above and beyond that, then there is disciplinary actions that can be taken by the Board of Nursing. So the APRNs in Missouri are licensed. If they were to go beyond their scope of education and training and a complaint was filed, then they would be disciplined if they were found to be going above and beyond what they're trained and educated to do. Third, just another important point to make, there's been some questions about the cost of collaboration. It goes anywhere from what Mrs. Armbruster had suggested was $650 a month, and we have one of our members that's actually here in this room that pays $50,000 per year to her collaborating physician. If you don't think that increases the cost of health care, then you're fooling yourself. So, you have the extremes. You have some people that don't pay anything, the APRNs and the healthcare systems that are, working, with physicians in the hospitals. And then you also have the extremes of $50,000 that has to be paid in order for that physician to sign off on charts. So I'd be happy to answer any additional questions and appreciate your time.
Thank you for your testimony. Any questions of this witness? Thank you. Next person to testify in support of.
Doug Mann with Planned Parenthood Great Rivers Action. Don't want to belabor the point either, but I will reiterate what Mr. Lee said about the maternity healthcare deserts, that it's very important that we are shoring those up and making sure that people that want to expand their families have the opportunity to do so healthily, and we're in great support of that, and we think that this bill will do just that. So happy to take any questions.
Thank you for your testimony. Any questions of this witness? Thank you. Next person to testify in support of.
Mr. Chairman, members of the committee, Mark Feigenbaum with Missouri Farm Bureau, testifying in favor of these bills. We think that this expansion of care is an essential step to providing health care to rural Missourians, and for those reasons we're in support, and I'd be happy to take any questions.
Thank you for your testimony. Any questions of this witness? Seeing none, next person to testify in support of.
Mr. Chairman, members of the committee, my name is Kaina Iman on behalf of the Missouri Nurses Association. As you can tell, Mr. Chair, Politics does make strange bedfellows, but I'm really happy for all our supporters in the room and look forward to working closely with our physician friends as well.
Thank you for your testimony. Any questions of this witness? Seeing none, anyone else to testify in support of? In opposition to? In support of?
Mr. Chair, members of the committee, Will Mars on behalf of Mercy Health System. Just want to go on record in support and echo the comments made by the Missouri Hospital Association, I think particularly on the 4,000-hour rule. That'd be very beneficial, and we just want to make sure we continue to provide access in rural areas. Happy to answer any questions.
Thank you for your testimony. Anyone questions for this witness? Thank you. Next person to testify in support of?
Chair, members of the committee, Jessica Petrie here for the Reach Healthcare Foundation and Kids Win Missouri. Just also want to go on record in support.
Thank you for testimony. Any questions of this witness? Seeing none, anyone else to testify in support of? In opposition to? For informational purposes only? Yes. Informational purposes only? Okay.
I can be unbiased about it, something. See, they know me. I guess my question is, Suzanne Opperman. I'm a psychiatric mental health nurse practitioner, but I practice therapy, so I do not have a collaborator. My question is for everyone, according to the collaboration rules, a physician is supposed to visit the clinic every 2 weeks and co-sign 10% of the notes or 20% of the notes if there's narcotics every 2 weeks. Who's holding that accountable? Why are we being held accountable for this part that they're supposed to do when they don't do it? So I have lots of people that I work with, that I talk to, and it's not happening. So why are we being put under the microscope when the physicians aren't being held accountable for their part?
Thank you for your testimony. Any questions of this witness? Seeing none, thank you. Anyone else to testify for informational purposes only? That concludes the hearing on Senate Bills 979 and 1016. We'll move on to Senate Bills 1016 and Senate Bill 1247 and 1445. Senator Brown and Senator Lewis, proceed when you're ready. We have a hard stop in 30 minutes. Keep that in mind when you get ready to testify, please.
For the record, I am Senator Ben Brown of the 26th District, and I'd like to thank the committee for the opportunity to present Senate Bill 1247, a bill that would expand access to health care in our state by allowing certified nurse anesthetists to practice to the full extent of their training. I have a long history of this particular piece of legislation. In fact, this was the very first bill I was lobbied on prior to even being sworn into office. The lobbyist's aim was to convince me that I should oppose this bill. After a good conversation, one in which I happened to mention my older brother was a surgeon, I was encouraged to reach out to him and get his thoughts. I spoke with him that next day, but the conversation did not go the direction the lobbyist thought it would. In fact, after an in-depth conversation, I walked away believing that this bill was something we very much needed in our state. My first year in the Senate, I served as the vice chair of the committee that heard this bill. The testimony in that hearing has stuck with me to this day. I heard doctors testifying in support, stating that throughout their medical training, they received maybe a month or so of specific training on anesthesia, while the CRNAs they were charged with supervising had years. I also heard from nursing students who attested to how the CRNA shortage in the state is exacerbated due to their fellow students flocking to other states after graduation. The reason? They preferred to work in a state where they could practice to the full extent of their training. The following session, I decided to sponsor this bill myself, and I have continued to sponsor it every year since. Another issue with the current law is that our state often asks CRNAs to choose between ensuring their patient's safety or preserving their license. We have an opportunity to fix that problem with this bill. Current law is being interpreted that a CRNA must get permission from a physician, podiatrist, optometrist, or dentist to order and administer anesthesia to patients. Even in the middle of surgery or in in an emergency when a physician isn't available. I've heard complaints from surgeons regarding how they have to sign off on the anesthesia provider's medications, while admitting they know little about anesthesia in comparison to the CRNA. Administrators complain about how this makes it difficult to recruit both surgeons and CRNAs to Missouri. Nothing in this bill changes the physician-led care model. No surgeries are happening without a physician. This bill only allows CRNAs to administer medications in licensed facilities. Independent CRNA pain management and ketamine clinics, a concern that had been raised by opponents in previous years, are expressly prohibited. It actually goes so far as to specifically prohibit a CRNA from writing prescriptions in lines 38 through 41. It also allows full autonomy for any facility that wants to have protocols in place by which CRNAs would have to follow. In other words, if a hospital wanted to have policies in place that are more stringent, they are able to do so. Finally, you may hear from opponents that this isn't a problem that needs to be addressed through a change in state law, and that it can simply be resolved through a hospital or facility's protocols. Well, perhaps that's an easy thing to say from, say, an anesthesiologist's perspective, but their licenses and livelihoods aren't the ones that are being put on the line every day for simply doing their job. Written protocols aren't a solution, and it is impossible to account for every potential situation and scenario in writing that could ever arise in a fast-paced operating room. Those that work in these settings acknowledge that written protocols will not completely solve this problem. However, this legislation does. So I urge the committee to join me in support of Senate Bill 1247.
Thank you. Senator Lewis, please.
Good morning. For the record, I'm State Senator Patty Lewis, representing Senate District 7 in Jackson County. Thank you for the opportunity to present Senate Bill 1445, which is identical to 1247. I think my colleague did a really nice job. I just want to add just a little bit of perspective based on the previous bill hearing and this one. When I first, you all know that I'm a nurse by background. I'm a RN, BSN trained. I am not a nurse practitioner. I am not a CRNA. And that's, quite frankly, because I didn't want to go back to school. But, I'm not that. And I found it very interesting. It wasn't until I set foot in this building that I witnessed this turf war thing. Like, in the hospitals I worked, we all knew our role. We all knew what we could do and work to help our patients. So I just want to kind of put that tone. I think, and on both of these bills, I have spoke with the opposition and really hope we can work to a compromise. I know we'll hear, a lot of stuff, but it's just very frustrating because I think, we have boards that we report to on both sides, whether you're a physician or a nurse, that if there's mistakes or disciplinary action needed to happen, that there's an avenue for that. So anyway, just wanted to point out that, and happy to take any questions.
Thank you both for presenting. And Senator Lewis, I think when we walked in this building, we found out a lot of stuff we didn't know.
Yes, that's the truth. Yeah.
Any questions of this witness? President, okay. Anyone to testify in support of, please come forward. We're going to limit these to 2 minutes because we have a hard stop in 25 minutes. So please be as quick as you can.
Okay, good morning, Senators. My name is Amy Brown. I'm a certified registered nurse anesthetist, or CRNA, and one of my skills is speaking fast, so I'll give it my best. I have the privilege of serving as our president this year, and I just wanted to talk to you about why these two bills are really important for our state and for our constituents and hospitals and CRNAs. So CRNAs are trusted across Missouri every day to provide safe anesthesia care. We're trusted for a variety of reasons, and that is our education. We begin with a bachelor's in nursing degree, and then we go to 2 years of minimum, 2 years of critical care experience, but on average, CRNAs have 4.5 years when they begin school. We have a 3-year doctoral nurse anesthesia program. We graduate with an average of 10,000 clinical hours. We're trained to safely select and administer controlled substances that are essential for anesthesia care. The Department of Health and Senior Services and its Bureau of Narcotics and Dangerous Drugs has identified a problem that they said needs to be fixed in our legislature. So they currently interpret our statute saying that a CRNA would need verbal permission from from the surgeon to give a patient the drugs needed for anesthesia in that perioperative period to keep them safe and pain-free. But CRNAs across our state are being forced to choose between patient safety and our license. So to be clear, these bills are not an expansion of practice, but codifying what currently happens in our state. The interpretation is problematic for many reasons. Before surgery, a patient may need pain medication or narcotic, and if the surgeon isn't there yet, we're not able to give it. Intraoperatively, the surgeon's obviously there, but they don't want to be bothered with anesthesia during the surgery. We were trained for that, and we're there to answer anesthesia questions and to provide that while they're there for the surgery. And then after a surgery, when the patient's in the recovery room, if they're experiencing pain and there's not a protocol in place, we would then need to call the surgeon to get a verbal order, delay patient care until we heard back, and delay getting them the pain medication they needed.
That's your timer. If you can kind of summarize, please.
Okay, so what I will say also is that, as they've talked about CRNAs leaving our state, I live 15 minutes from the state line, so I practice in Missouri, but I also practice in Kansas, where we don't have this unsafe issue. So our request is that you fix this unsafe issue in Missouri.
Thank you for your testimony. Any questions of this witness? Anyone to testify in opposition to, please come forward. None? Hold on. I will say, really? Please proceed when ready.
Good morning. My name is Jim Kelly, and I'm a cardiac anesthesiologist in Kansas City, Missouri, and work at the Mid-America Heart Institute at St. Luke's. I'm testifying on behalf of myself and the Missouri State Medical Association. I've been practicing in Kansas City since 1992. I personally perform anesthetics and also work in the care team model with nurse anesthetists and anesthesiologist assistants. The above-mentioned bill seeks to remove physician supervision from the delivery of anesthesia in the state of Missouri. This would be a step backwards for the citizens of Missouri. This legislation, as has recently been said, is being presented to alleviate a nuance in the operating room that states that nurse anesthetists cannot give medications without talking to the surgeon. We have a letter from DHSS stating that their current interpretation is that this can be alleviated with a protocol. This was done 15 to 18 years ago in collaboration with both the Missouri Association of Nurse Anesthetists and the Missouri Society of Anesthesiologists. That protocol is readily available, can be signed before a surgery, and alleviates all the needs for talking to a surgeon during the case. I have a copy of that letter, and I'm happy to provide the committee with that letter. This bill also has a possibility of an unintended loophole to allow pain management practices. I think we need to recognize that ketamine is a Schedule III drug, which has a high abuse potential, as recently noted by the death of Matthew Perry from abuse. In closing, I think that this bill is really a solution looking for a problem that doesn't exist. We are happy to work with our anesthesiologist assistants and nurse anesthetists to provide care, and it has been demonstrated that that is the best way to provide care. I will also provide the committee with a survey that was done in all 8 congressional districts 2 years ago that overwhelmingly noted patients want physicians involved in their anesthesia care and pain management. Happy to answer any questions.
Thank you for your testimony. Any questions of this witness? Next person to testify in support of, please have your witness form ready. In support of.
Thank you, Mr. Chair. Jamie Cavanaugh with Pacific Legal Foundation. I just wanted to sign in publicly in support for both of these bills.
Thank you for your testimony. Anyone, any questions for this witness? Next person to testify in opposition to. Proceed when you're ready.
Mr. Chairman, my name is Dr. Kathy Perryman, and I'm here as a physician anesthesiologist who is in opposition of Senate Bill 1247 as it modifies provisions relating to certified registered nurse anesthetists. And I represent myself and the Missouri Society of Anesthesiologists.
Are you in opposition to both bills?
Yes. I have a unique perspective on this subject because before I became a physician and then an anesthesiologist, I was a nurse anesthetist in my early career. I decided to go to medical school and then complete a residency and fellowship another 8 years after CRNA school because I recognized that I wanted and needed the additional education and training to gain the knowledge base and skills I needed to be capable of safely caring for patients on my own. And when I was at CRNA, I knew that I could only practice safely with the oversight of a physician who had those advanced skills and knowledge. In rural communities, when CRNAs are working with a physician who's usually a surgeon, the physician is the practitioner that should be managing the patient's care before, during, and after surgery. They take full responsibility of that patient and in the operating room. They have the advanced skills, the advanced knowledge to fully account for the patient's entire health and should be kept in the position of supervising CRNAs in rural practices to keep the patients safe. The administration of anesthetics can these drugs are strong and can be very dangerous. And I've supervised nurse anesthetists for decades, and they are very trustworthy members of the anesthesia care team. I enjoyed working with them very much. But I knew, and the ones that I worked with knew, that we had to collaborate because the knowledge bases that we had were not the same. And they accepted the supervision and willingly. So we have to keep guardrails in place to keep the patient safe. And that there are a lot of them already in place, as Dr. Kelly discussed the protocols that are in place.
If you could summarize now, please. Your timer just went off.
Okay. I'm also concerned about the potential for the bill reaching beyond the operating room and allowing them to run ketamine clinics. I think that could be very dangerous. And so I encourage you to vote against these bills.
Thank you for your testimony. Any questions of this witness? Seeing none, next person to testify in support of.
Thank you very much, Mr. Chairman. I gave to the security person my testimony on all the bills today. There were a lot of people I couldn't get in before. But when it comes to nurse anesthetists, I think that we have deserts throughout our county, just like with the nurse practitioners. I'm going to be in favor of all four of these bills because we have deserts. Some areas of our state, we have 3 counties in which there's not a physician available or practicing or any emergency room availability. Because of that shortage that the industry or the medical field has been facing for the last probably 5 years, maybe even longer, I feel that all 4 of these bills are necessary to meet the needs of medical needs throughout our state. For those reasons, I support these bills. Thank you very much, Mr.
Thank you
Chairman.
for your testimony. Any questions of this witness? Next witness to testify in opposition to.
Thank you, Mr. Chairman, members of the committee. David Jackson, registered lobbyist for Jefferson City Medical Group. Want to go on record in opposition. I was the lobbyist that talked to the bill sponsor, was the first person to lobby him on any issue, and his depiction of that conversation is accurate. I think we agree to disagree on this. But, I think in regards to the bill itself, I do want to address the ketamine piece. Because there was previous language that specifically talked about pain clinics and referenced ketamine 3 years ago, 4 years ago, that has been removed. But as we all know, sometimes when something's silent and not mentioned, it can still have significant authorization and power. And so under current law right now, a CRNA, when they are administering anesthesia, that controlled substance has to be ordered under somebody's DEA number. and it has to be supervised by a physician. And what this does is allows a CRNA to order and administer controlled substances without physician oversight and without physician sign-off and without a physician on site. And so when you see these med spas that pop up where you can go get IV infusions for hangovers or for migraines, and now trending with a handful of them around the state where you can do ketamine administration, under current law, there should be a physician there on site why that ketamine is being administered, and there should be a physician psychiatrist who's making that clinical diagnosis and whether or not that patient is suitable for ketamine. And that's a whole nother conversation if we want to talk about access to ketamine and how it's being used for mental health. It's a very, very, very powerful drug. And so by this being silent and not having any guardrails in it, what this does is allows a CRNA to treat somebody who comes in for a migraine, get a ketamine infusion, and not have any physician signing off on that without any recourse or anything.
If you could summarize, please.
Yeah. So I'm not suggesting that's the intent of all of the people lined up behind me to testify on this, but it is absolutely a consequence and something that we believe is a core issue and problem in this, and something that the real problem that's being expressed here can be solved through a protocol, and those protocols are easier to pass in a hospital than it is to pass legislation. Thank you.
Thank you for your testimony. Any questions of this witness? Seeing none, next person to testify in support of, please come forward.
Good morning. My name is Denise Stite. I am a certified registered nurse anesthetist in Kansas City. I am testifying in support of these bills. I wanted to clarify some of the comments that have been made regarding some misclarification. So for the protocols, so current law is that we do have to have a protocol or a signed order. The protocols were suggested by the Bureau as a temporary solution, kind of like a Band-Aid fix. We have tried the protocols and found that they do not work. So that is why we are seeking these bills. There's no protocol that can account for every single patient interaction, complication, past medical history, and anesthesia requires that patient-specific component to provide good, safe care. The supervision, so this bill does not remove supervision. Former versions did. This one does not. It simply recognizes that the CRNA may, in essence, do their job. So I select the medication, I take the medication out of the machine, and I give the medication. And this requires moment-to-moment decisions that cannot be delayed. The licensed facilities, and the ketamine pain clinic comment, so as was testified that was a portion of the bill previously, that has since been taken out and was remediated by inserting that facilities that are currently licensed in Missouri. So the facilities licensed in Missouri, as determined by the state, are hospitals and surgery centers. They are not ketamine clinics. They are not pain clinics. This is only for licensed facilities. If that is decided by to license other components.
If you could summarize, please.
Yes, absolutely. So the bill is not supervision removal. It is not a scope expansion. It's continuing to do what I do every day. It is not prescriptive authority, and that is explicitly listed, and supporting the CRNAs and our patients for timely care. Thank you. Any questions?
I have a question. Even with the protocol that one person talked about earlier, their agreement, you still select the amount and drug to give, is that right?
I do. So yes, the protocols that we have shared and encouraged hospitals and CRNAs to use over the past 6 years, they are just not accounting for every single patient situation. But on the protocol, it's a wide variety of all of the controlled substances, all of the dosages, a wide range, and kind of just during the anesthetic to select as I see fit. So
Why-
in essence,
why are you
there's no
trusted?
change.
Why are you trusted to do this? Because that's in the scope of your training. Is that why?
Yes, absolutely. So the training specific piece is also a little bit misleading. So in the report that we have 25 to 300 hours, that is anesthesia specific hours to 3,000 anesthesia specific hours versus the other column that was listed was 10,000 plus total hours. So that's not an equal comparison to take our anesthesia hours and someone else's total clinical time, including anesthesia hours. So yes, everything that we do in our training is directly related to anesthesia. So I would agree it's a narrower scope, but that makes us experts in the anesthesia field.
Okay, thank you for your testimony. Any questions of this witness? Next person to testify in opposition to?
Good morning, Mr. Chairman, members of the committee. My name is Rachel Bauer, here to go on record on opposition on behalf of the Missouri Association of Osteopathic Physicians and Surgeons. Thank you.
Thank you for your testimony. Any questions of this witness? Next person to testify in support of?
Good morning, Mr. Chairman, members of the committee. My name is Ryan Sumler. I'm a student registered nurse anesthetist at Webster University in St. Louis. I wanted to start by touching on one of the points that Senator Brown made. There was data collected from each school in St. Louis or in the state about what students do after they graduate. And it was found that over 40% of students leave after graduation. They leave the state due to these restrictions. I felt compelled today to speak before y'all because I may be one of those. I'm originally from Georgia. I moved here for school, and I have found that Georgia's framework encompasses anesthesia practice completely differently than Missouri does. The practice of anesthesia is covered under Georgia's Nurse Practice Act, and the fact of choosing and administering medications falls under anesthesia practice rather than the way Missouri interprets it through the BNDD. There's no confusion about whether CRNAs have to get permission from a surgeon in Georgia. It is under their scope of practice. They have clear definitions of what they can and can't do, and the ambiguity of the way Missouri does it is one of the reasons that I'm considering going back to Georgia to practice. It's been said multiple times, this bill does not expand CRNA practice. It does not create new authority. All it does is clarify that what we do on a daily basis is within Missouri law. I'd be happy to answer any questions.
Thank you for your testimony. Always remember the Cardinals have more World Series championships in the band.
Thank you.
So we need you to stay here. Any questions of this witness? Thank you. Anyone else to testify in opposition to? Anyone else in support of? Yes.
Sorry, can't break for lunch yet. I'll finish quickly.
We got about 5 minutes, and then we got to evacuate.
Good morning, Mr. Chairman and Senators. I'd like to thank Senator Brown, Senator Lewis for bringing this up. I'm going to give you a different perspective. My name is Mike Burcham. I'm a retired CEO, mostly in the critical access hospital and rural environment, a lot of time here in Missouri, and I'm also a fellow of the American College of Healthcare Executives. I'm here today in support of SB1247 and 1445. One of the main reasons, and you'll find out I'm very passionate, is Missouri rural health is at a critical breaking point. You've heard it all today. Things are a mess out there. We've got to do some things to fix it, and part of it is to be in support of things that can not create some of these things that are going to lead to deserts out there. My direct experience with CRNAs over my 15 years as a CEO of rural hospitals, the relationship between the surgeon and the CRNA has always been excellent, both practicing at high levels as a team to achieve a safe and quality patient experience. One of the things that keeps Missouri hospitals open today is the fact that they've got access to 340B programs and they've got strong CRNAs. The outpatient surgical programs in these hospitals is keeping them open. We only have 35 remaining critical access hospitals in the state of Missouri, and half of the remaining ones are at risk of closure right now. And one of the things that's keeping them open is having active and credentialed surgical teams. I can speak firsthand how difficult it is to recruit CRNAs because I also was a critical access hospital in Nebraska. We don't have this problem because of the practice laws that they have there. In speaking with Missouri CRNAs before this, most of them just want to be able to practice at their defined scope of practice that is given to them with their training and through organizations like MOANA and AANA. I would hope that passing this bill will help retain and
Can you
maintain.
summarize, please?
Okay, will help maintain these surgical programs out there. I strongly support CRNAs. And I very positive with the Missouri folks that came up here that are surgeons or anesthesiologists, but I can tell you I've had 10 different surgical procedures over the last 15 years, and I know who's taking care of me. As a clinical respiratory therapist throughout my early career, I know what it takes to manage an airway and keep people alive in an ICU. These people do something very similar. And all my surgeries were provided by CRNAs. I survived every one of them because I know who they were and who was taking care of my airway. So I do support this strongly.
Thank you for your testimony. While you were talking, I thought you were going to need some help there for a minute.
Well, I know I would be in good shape, so I can't intubate myself, but I can count on them to help me. Thank
Any
you.
questions of this witness? Next person to testify in support of?
I didn't think I was going to testify today, but here we are. My name is Jean Wiggins. I am a psychiatric nurse practitioner and clinical nurse specialist for 18 years. I have been a rural Missouri psych NP and clinical nurse specialist and nurse in Missouri for 28 years. I'm an 8th generation Missourian and have never left rural Missouri. Long story short, I've had 3 very serious spinal surgeries at MOI, which is Missouri Orthopedic Institute, and at MU, and all 3 I had CRNAs, and I support my CRNA colleagues. So I am very much for these.
Thank you for your testimony. Any questions of this witness? Anyone else to testify in support of?
Good morning. I was not planning on testifying, but I'm here because I'm feeling very passionate about this. My name is Abigail O'Leary, and I am a student registered nurse anesthetist at University Health Truman Medical Center. I just wanted to go on record and say that as somebody who's currently studying for her boards, we do need to know down to a molecular level what these medications are doing to our patients. And so we understand from a grandiose level all the way down to that very molecular level what we're doing to our patients every day in the OR and how that's going to affect them and their pathophysiology that they might be presenting with. Another really important thing to know is that there are other medications beyond narcotics that we administer that are considered controlled substances. So medications such as ephedrine, which boosts your blood pressure, is a medication that would fall under this bill, and that would be a potentially life-saving medication that we would have to get permission to give before we're able to give it if we were interpreting this the way that the BNDD is interpreting it. So I just wanted to go on record and say that there's a couple of clarification things, but as a student, you know, we're learning this. This is very important for us to know, and I won't pass my boards without knowing it.
Thank you for your testimony. Any questions of this witness? Seeing none, anyone else to testify in support of? Opposition to? Informational purposes only? Going once, going twice? No further business coming before the committee. I now make a motion to adjourn. Do I have a second? Second. We are adjourned. Thank you. Thank you. Thank you. Oh, you're welcome. That was not too bad. Worked out well. Yeah, exactly.